I would expect a lower gradient. What's interesting is the 26 and the 29, there's no difference in the geometry. The only difference is the tissue went from non-resilient to resilient, yet the gradients are lower. Any speculation as to why that might be?
I think it just could be that the tissue isn't as stiff, perhaps. I think I think Raj has shown data that if you do these 4-day CT at 30 days, you see some high incidence of thickening or halt, and that is asymptomatic, maybe not picked up by echo. It's possible that the leaflets are just moving better.
How much of a gradient difference is there in absolute terms?
It's between 4 and 5, but statistically it's significant.
Yeah, and it's interesting. I mean, we'll talk a little bit about this later, but we all rely on echocardiography, to monitor these patients because obviously it's non-invasive and it's easy to get. It doesn't harm the patient, but there is a discordance between what you measure with your echo on the chest and what you measure invasively with a catheter in the ventricle, which is another phenomenon which is interesting, and it's complicated, but it really comes down to the physics of what's going on and the original Bernoulli equation, which is like this long. And as you know, a lot of those numbers we don't know for the human body, so they were either assumed to be constant or not important, so that it was shortened to 4V squared. And that works well for native valve disease, but it doesn't seem to work well once you replace the valve with some artificial device, whether it be a mechanical valve, bioprosthetic valve. And I have to say that this is just my own personal feeling, is that for years the surgeons were were getting the bad end of the straw, if you will, on this, saying, hey, this guy you did a valve on, the gradient's very high by echo, and the surgeon would say, look, I put the biggest physical device I could put in there. I was in the OR, you were not. I don't want to hear about the gradients. And so for years we did that, and then now all of a sudden, because we're involved with TAVR, now we're starting to care about these gradients and taking it more seriously and trying to understand, invasive gradient versus echo-derived gradient, et cetera. And we had I think we had less personal interest / skin in the game, so to speak, when it was just a surgical valve. And so I think that a lot of what the surgeons were saying for years turns out to be very well, essentially true, that you may have a high echo gradient, but you catheterize someone for various reasons and you find that gradient is actually very low. And so this whole notion of patient prosthesis mismatch is a bit complicated because we have formulas to calculate it by echo, and sure enough we can see a high gradient in a bigger person, but you can also see a high gradient for other reasons. Someone's anemic, has a high flow state, etc. And true aortic stenosis, the way it was defined originally back in the day, was a pressure differential between your LV pressure and your aortic pressure. And if you don't have that pressure differential, not velocity, but pressure differential, you don't have aortic stenosis. So if your gradient is 40 by echo, but you do a catheterization and the gradient is 0, there's no aortic stenosis, despite what the echo says. So patients that have real, true patient prosthesis mismatch, yes, they'll have a high gradient by echo, but if you catheterize them, there's no gradient invasively. There's no true AS there. But if you have true patient prosthesis mismatch, there will be an invasive gradient as well as an echo-based gradient. So it's complicated, and we don't want to go back to the old days of catheterizing everybody to find out how they're doing, because those days are over. But for some unique cases, sometimes it's meaningful and useful.
I have a question. How often do you take somebody back to repeat a cath when the referring is concerned?
It's rare, but I mean, that's a great question. But, well, I'll tell you what we do. Paul and I do an invasive gradient on every case at the conclusion. And I know a lot of folks don't do that. They put in the valve and it looks good and you walk away. But we do an invasive gradient. And the reason why we do that is if the next day or the day after that, the gradient is higher by echo, which it often is, we don't know if that's a real problem with the valve or a artificial problem, if you will. But if we had an invasive gradient, we know that there was no problem at the time of the implant. So it's not that we didn't deploy it all the way or there was some sort of issue with it. But to answer your question, Joe, it's tricky. Some patients will come back and they'll be referred back from a colleague saying, hey, Mr. Jones's echo gradient is getting higher and higher and higher. My first question is always, well, how does Mr. Jones feel? If Mr. Jones is short of breath or has symptoms, I'm a lot more, the hair on the back of my neck stands up, there may be a problem. If they have no symptoms, then the question is, okay, is there evidence of a structural valve problem, like you said? So that's going to require some imaging. And different places do different things. We typically do a 4D CT to look for leaflet thickening or abnormality. If you see leaflet thickening, it's presumed halt, and that's abnormal. And then we typically anticoagulate them and then see what happens. If it goes away, great. If it doesn't go away, there's something going on. If we don't see anything by imaging, so by CT it looks clean but the gradient is high, those are the patients that we will end up getting, bringing back and catheterizing. Because we don't have an obvious structural explanation for the elevated gradient, but if you catheterize them, many times you'll find that there is no gradient. And so for reasons I can't fully explain, their velocity is elevated, whether it's a high flow state, anemia, I don't know why. We see it in dialysis patients with fistulas, fistulas. We see it in liver disease patients with high output. And sometimes we just don't have an explanation. They're not anemic, they don't have liver disease as far as we know, and we just say, we don't know. But they get reclassified as a high gradient but normally functioning valve, and it's just high by echo. And so it's not the absolute number that we really care about, it's sort of the change in that. And so what we've also learned looking at the data is that almost everybody's echo gradient goes up in the first 30 days, and that's not a bad thing, it's a good thing. So there's a paper that by Amr Abbas and colleagues that was really, really well done that showed that that's primarily due to LV recovery. So, and that's a good thing, we want the LV to recover. So I don't look at my echo the day after or 2 days after or before the patient goes home and say, well, the gradient's higher now. I look at the 30-day echo. That's my new baseline after LV recovery has happened. Because it always goes up at 30 days. It doesn't mean everybody needs a 4D CT, in my opinion, or a further evaluation. That's just how we do it. What do you guys do?
Very similar, yeah. And I guess I'm probably more worried about the echo gradients that stay low, lower EF. Those are the patients that tend to have the worst outcomes. But we have a handful of patients that, we see these, everybody's gradients higher at day one. And, we do invasive gradients also. We have a tendency to have a low threshold to get a 4D CT if the gradients are up at any point in that follow-up.
Dan, what do you guys do? Do you do an invasive gradient, everybody?
Yeah, we do, because, being the surgeon here, we know that the structure of the native aortic valve is completely different than the structure of a prosthetic valve. Just the nature of how everything from the aortic valve to the root, to the sinuses, to the sinotubular junction function together when it's native versus when there's something rigid and prosthetic is completely different. And so we check a gradient on everybody directly because it is a base point for us. It gives you kind of a point to say, hey, here's your baseline, let's progress and watch it on echo because it's easier to do, but we know that it's not completely accurate. We also base it off of symptoms. A couple comments on tissue durability too. Surgeons, we've been doing this for decades. We've been progressing through, aldehyde processes from high pressurized aldehyde into non-pressurized aldehyde because the calcification rate is slower. We've looked at capping aldehyde ends, which is what the RESILIA tissue does. But you bring up a point that these valves still develop halt, and I'll tell you there's some things about the tissue that unless you go and study how it's been developed, you don't see. They're not completely inert. There's still some immunological response that we have to putting bovine tissue in. Even though it's not an immediate response and we don't see quick thrombosis, there is a subset of patients that will have a reaction to that tissue. We see it surgically, and we tried for a while to put people on blood thinners. We'll put them on Coumadin or something for 3 months after a valve implant. And sometimes it helps, sometimes it doesn't. So there's still a lot that's gonna come to, I think, valve durability in terms of the tissue, but there's a lot of other things that come into valve durability. You brought up the idea of like sizing. So if you look at you guys probably haven't seen a surgeon's sizing chart, but they put things in red, yellow, and green in terms of based on their BMI and their BSA and the different valve sizes for the valves. And so the valve companies produce these, but if you look at it, the majority of it's always in green. You can have a BSA of 2 and you can have an